Okay, I'm going to spend the next 20 minutes or so discussing the guidelines on prevention of cardiovascular disease in people with diabetes. I think many of you are aware that over the last 6 to 8 months, there have been some new guidelines from North America regarding blood pressure and lipids. And those have been, should I say, very evidence-based. So they are very heavy on the use of clinical evidence. But my own thinking about guidelines is that in a given healthcare setting, we will need to interpret the clinical evidence and then use the guidelines as a bridge, with the understanding of our own healthcare setting into guidelines which can be implemented for use, particularly in primary care and perhaps also in other care settings. So it's with this in mind that we have looked at the North American guidelines and then formulated our own. In fact, we formulated ours first. We looked at theirs and then we decided what we needed to change or otherwise. Okay, so I start off with this, which is a fairly commonly stated fact. People with diabetes have a 2 to 4 times risk of clinical coronary artery disease and stroke when compared to people without diabetes. And I think I just wanted to remind all of us again that this is in fact the case. And this is evidence from the Strong Heart study looking at people without coronary artery disease here, and here this men and women. And those with diabetes have about a 2-fold increase in, this is cumulative incidence of CHD. This is in men, and again, this is in women. In women, it's slightly more. And perhaps in women, the fatal ones are a bit disproportionately increased and compared to the overall increase compared to non-diabetics. So just to say that this is still the case and sets a background for our discussion. And it's again important to have a global risk assessment and risk factor management. And this, as evidence, I'm citing the Steno 2 study where the study looked at intensive control of several risk factors and achieved a good outcome of 50% relative risk reduction in all-cause mortality and cardiovascular mortality after 13 years. So it's important for us to look through the whole list of risk factors with our patients, and of course the non-modifiable ones like age. We can't keep ourselves from aging, gender, etc. Besides that, I think the rest then you can be using them as discussion points with the patient to modify their cardiovascular risk. Okay, I turn quickly to hypertension. As far as hypertension is concerned, it is relevant not only for prevention of cardiovascular disease, it's also important for microvascular outcomes as well. And first, maybe we look at the systolic blood pressure target. And over the years, several clinical trials have helped us define what might be a good target systolic blood pressure range. And I start off with UKPDS, which I mentioned earlier on. And in the UKPDS, the systolic blood pressure attained was about 144 mean as compared to close to 160 here. And there were improvements in diabetes-related endpoints, death, as well as in stroke and microvascular disease as well. So that was a blood pressure target which was attained, which was still above the 140 range, 144. Subsequent trials looked at lower blood pressure targets. Now, you might argue that the advanced trial was not really a blood pressure study because it included people who were said to be normotensive, not necessarily hypertensive, but it did try to bring the patient's blood pressure down. And this study managed to achieve a systolic blood pressure target of 134 as compared to 140. And again, it managed to show improvements in several outcomes, including renal outcomes, as well as cardiovascular death up here. So I think this is you can argue whether this trial should be included as evidence or not. And in the recent North American guidelines on hypertension, they were excluded because they say it was not a hypertension trial. Okay, and the next trial which might help us define limits for systolic blood pressure targets might be the Accord study, which looked at the effect of a target systolic blood pressure of below 120 millimeters mercury on major cardiovascular events amongst high-risk persons with type 2 diabetes. So it was comparing a target of below 120 versus a target of below 140. And the endpoint was the usual MACE, cardiovascular death, non-fatal MI, and stroke, and the follow-up was 4.7 years. And in this study, the achieved blood pressure for the two arms, here it was 119, as I remember, but here it was above 130. I can't remember exactly what it is, but it looks like about 133, 134, systolic blood pressure. And it did not show any difference in the outcomes. So in other words, even if you brought systolic blood pressure down further from 130 odd to 119, it didn't show a difference in the overall cardiovascular outcomes, although stroke rates were slightly improved. Now, okay, so it didn't show improvement in outcomes, but is there a lower level at which you might hit harm, potential for harm? So I think this is not a real trial trying to answer this question, but it was an epidemiologic analysis of the INVEST study looking at the subgroup with diabetes. The INVEST study, I think most of the patients actually had coronary artery disease, but they were looking at the subgroup with diabetes. And looking at this epidemiologic analysis, the people with a systolic blood pressure lower than 110 millimeters mercury actually had significantly higher risk for all-cause mortality as compared to those above, say, 120, 125 millimeters mercury. This is systolic blood pressure. So perhaps it's helping us define a lower limit as well, right? So we come down from 140 odd and we hit 130 odd, still some benefit. And then going down to 119, we said about the Accord study, it didn't show much benefit. And in fact, there's some potential for harm. So we better stop about there. So I think you go on to the diastolic blood pressure target, then later on you define both systolic and diastolic blood pressure targets. So you turn on to diastolic blood pressure. Again, there have been several trials, but if you look at, again, UKPDS, the first diastolic blood pressure target was about 82 here, and it gave benefits. Well, we could say that it's hard to tease out the effect between the systolic and the diastolic blood pressure targets, but in any case, it was 82 in the UKPDS. And the other study, which is often cited to support this diastolic blood pressure target of 80 and below, is the HOT study. And it's again a subgroup analysis looking at the patients with diabetes at baseline. And this shows that if you achieve a diastolic blood pressure of below 80, then you have less major cardiovascular events per 1,000 patient years. You see here, there's lower than up here. Again, you can take the other perspective that, this is a subgroup analysis of a majors trial, and we can't really use this, and hence the North American stance is 90. But if you do think that, hey, this evidence can be taken, the diastolic blood pressure target is then can be taken as 80. And this is the statement that we have in the CPG for patients with type 2 diabetes who have hypertension and acceptable treatment initiation, and target blood pressure target is 140 or below 140, 80 millimeters mercury. And just a caveat, for older patients, more conservative blood pressure targets are acceptable. And we're looking at people, say, above 80, where blood pressure target of perhaps 150 systolic will be acceptable. Okay, if you turn away from blood pressure targets and look at any preferred antihypertensive agents in people with diabetes, we can cite the MicroHope study, which is looking at using either ramipril or placebo. Again, it's a subgroup analysis of the main HOPE study, and looking at primary outcome of cardiovascular mortality, MI, etc. and nephropathy as a secondary outcome. There was a difference when exposed to ramipril here versus placebo. This is placebo with higher incidence of outcome, and ramipril here. Same for all-cause mortality. Here you may argue that if there's a difference in the blood pressure attained, meaning like the advantage in having a lower primary outcome might be attributed to the lower blood pressure rather than to a particular agent. No? So you might say you need to balance the blood pressure attained and using two different agents and see which agent is better. And only then can you choose a better agent. And so there was this Benedict trial which looked at people with type 2 diabetes using an ACE inhibitor, tandem versus verapamil. There were several arms, including a combination arm, and the target blood pressure was 120/80. And in this study, they had equal blood pressure levels at the end of the study and at mean blood pressure as well. And they still managed to achieve a better outcome for the ACE inhibitor group. And this is one of the studies sometimes cited as showing evidence that using ACE inhibitor is preferred, at least in having a better renal endpoint, if you like. Okay, so the evidence, the CPG statement, and ACE inhibitor or ARB should be included as part of antihypertensive regimen for people with type 2 diabetes requiring pharmacotherapy for hypertension unless not well tolerated. So just a caveat, if you do start or you do need to adjust dose of ARB and ACE inhibitor, it's useful to check the potassium and creatinine at some point. Okay, so in the glycemia part of the talk, there was individualization of target and perhaps some degree of personalization of agents. And I think this same idea can carry over into blood pressure management as well. Okay, I switch gears and we go into lipids. Okay, I think a few motherhood statements about measurement of lipids, which these are repeated from previous guidelines. So all people with type 2 diabetes should have a lipid profile measured, and this should be obtained after fasting, and then they should be perhaps measured every year. Again, we might come up for some discussion on this. We switch gears to LDL cholesterol goals, and again, I think you'll be aware that in the last 6 to 8 months, there was publication of North American guidelines on cholesterol lowering. No? And there they adopted the approach of risk group and then deciding on the intensity of statin treatment for a particular risk group. Whereas traditionally we've been used to LDL cholesterol levels for initiation and targets. So how do you rationalize this now? Are we ready to abandon targets? Well, I thought actually the two approaches are fairly similar. If you look at risk groups, and then you say one group you need moderate intensity statin, and next you need high intensity statin, it actually means that you are adopting slightly different targets between these two groups. If you use moderate intensity statin, you're likely to achieve perhaps 2.6 millimole of LDL cholesterol. If you use high intensity statin, you might achieve 2.1, 1.8 LDL cholesterol level. So it's actually not very disparate. In the end, it's about the same. And we are still able then to attain some idea of the LDL cholesterol level of our patients. Now, okay, so recent cholesterol lowering trials have not used LDL cholesterol targets. I'm referring to North American publications, but have used particular statin doses for a given group of patients with specified CV risk level. However, in clinical practice, periodic measurement of LDL cholesterol is useful for looking at adherence, at drift, and hence guidance on desirable level of LDL cholesterol is still needed. And I think there are two tenets to that, if you like. The first is that if you believe that the main effect of statins is on LDL cholesterol, then I think sort of like it's intuitive to then look at the LDL cholesterol level to see whether the statin is likely to do its work or not. And secondly, I think in a trial setting, it's a bit different from when you treat a patient. In a trial setting, you are doing an intervention, you let it be, and then you want to see what are the outcomes later on. Whereas when you face the patient, it's a bit different. The patient would be interested to know whether you have managed his risk not to the level that he is comfortable with or not. And you want to get some assurance that, your LDL cholesterol has come down some, and hopefully you won't have that adverse outcome, whereas in the trial, you might be waiting for those outcomes to happen. So I think there's a bit different there. So I think there's been a lot of commentary about the targets being removed. I'm not sure whether the next guideline group would remove the targets or not, but in this few months of thinking we thought maybe we should still retain the targets. And let's see what happens the next guidelines. Okay, so again, but this going back to what is, I think, already well understood by all of us. I think there's now no doubt that the statins are useful in lowering cholesterol, and this is just a meta-analysis from the cholesterol treatment trialist collaboration. And if you looked at this baseline LDL cholesterol in the diabetes and a no diabetes group, they began at about a mean of 3.4 to 3.89, and then at the end of trial, the LDL cholesterol was reduced about 1.1 millimolar, which brought them to maybe about 2.4 or thereabouts, no? 2.4, 2.3. So this, and of course they all had good outcomes here. You can see, the good outcomes, whether you have diabetes or no diabetes, you had good outcomes, and you do this level of LDL cholesterol lowering in terms of major coronary event or coronary revascularization, etc. So I think there is quite a lot of evidence that this intensity of cholesterol lowering to this level brings about benefits to our patients with diabetes. Okay, so this statement, the majority of patients with type 2 diabetes should have a primary LDL cholesterol goal of less than 2.6 millimolar and should receive medical nutrition and functional therapy to achieve this goal. Okay, then we go on to those people with diabetes whom we think have additional risks on top of diabetes. And I'm referring to those people who have diabetes and additional cardiovascular disease, such as those who already have MI and yet they have diabetes as well. So they are high-risk patients. And in this, I'm citing the evidence from the TNT diabetes substudy, where 1,500 patients with diabetes and stable CHD with initial LDL cholesterol, very similar to what the collaboration study was, 3.4, and were randomized to either low-dose atorvastatin or high-dose atorvastatin. And this was a follow-up, and these were the endpoints that they looked at. And when they use low-dose atorvastatin, they achieve a target of about 2.5, and they use high-dose atorvastatin, they achieve a target of 2, okay? And it did show a big difference in the outcomes over time. And so I think it gives rise to, okay, the statement is at the end. So I think we adopted the target LDL cholesterol level of 2.1 based on some of these studies. We can discuss that later on if necessary. Okay, now that was one high-risk group. That was people with diabetes and existing coronary artery disease. The other fairly well-recognized high-risk group amongst people with diabetes is those with diabetes and chronic kidney disease. And I'm citing the SHARP study, the study of heart and renal protection, which is a study looking at some 9,000 subjects, 3,000 on dialysis and 6,000 who are not on dialysis, but all at CKD 3 and beyond. And this is not just a diabetes study, so this was only 23% of subjects had diabetes, and patients were assigned to simvastatin plus ezetimibe versus matching placebo. And outcomes were as such here. And just to say first that whether there were the patients or the subjects in the trial had diabetes or not, they had, in fact, the people with diabetes had maybe slightly better outcomes, as this point estimate here is slightly further away than this from the unity line. So people with diabetes definitely seem to have benefit with statin therapy in this study. This is a study on people with diabetes and CKD. But if you looked at the CKD stage, CKD stage 3, 4, 5, and then people on dialysis, And you'll find that here, this point estimate is quite close to the unity line, and then it moves leftwards, and people with earlier stage CKD seem to benefit more with intense statin therapy, if you like, or LDL target, or lower LDL target. Whereas if they moved towards CKD5, and well, if they're on dialysis, then it crosses the unity line, and there's no benefit if the patient is on maintenance hemodialysis. Okay, so the achieved LDL target levels are here again, for those of you who are interested. And with these studies, we came up with this statement, which is that patients with diabetes who have overt cardiovascular disease, that's from a TNT study, or chronic kidney disease but are not on the maintenance hemodialysis, it's on a SHARP study, have low density LDL, have LDL cholesterol level lowered with a combination of dietary and pharmaceutical means to a target of 2.1. So we chose a target of 2.1 millimolar for this group of subjects. Okay, I think again, this part, these are repeats, no? I think statin is the agent of choice. When making a therapeutic decision with the patient, the potential benefits of adding and increasing lipid-lowering pharmacological treatment needs to be considered together with the potential risk of such treatment. It's important, but and should not be taken lightly, this statement. Huh? And when we want to increase the dose of a statin, or we want to initiate a statin, we should bear this in mind. Okay, we shift again. We go, we now discuss antiplatelet therapy. Okay, antiplatelet therapy is recommended for secondary prevention. In other words, if you have a patient with diabetes and he has had a stroke or he has coronary artery disease, there's no question that if he can tolerate it and there are no contraindications, you can provide him with antiplatelet therapy. The contention is in the primary prevention. And that's because recent trials where antiplatelet agents were used on patients with diabetes in primary prevention. In other words, those who do not already have coronary artery disease, do not already have stroke, etc., they didn't show any benefits. This is a meta-analysis of these trials. Whenever there are patients with diabetes, or some of these trials were actually dedicated to patients with diabetes, such as JPAD, they did not show any benefit. One is coronary artery disease, and the other one is stroke. So no benefits in stroke outcomes, no benefit in coronary artery disease outcomes. So what do? I mean, intuitively, you give antiplatelet agents for people with diabetes because, I mean, it's true. There's some data suggesting that for people with diabetes, perhaps even 20% might have silent coronary artery disease. So antiplatelet therapy, we should try to find those 20% of people. And I think the original ideas about aspirin therapy was that you should consider aspirin therapy as primary prevention in people who have a cardiovascular risk of 10-year risk of more than 10%. So I suppose that's what we are traditionally used to. That is on the potential benefit side. But the potential risk side for aspirin would be hemorrhagic stroke of 1 in 10,000 people annually. That's one study I came across. We looked at this. I think this is a review. And gastrointestinal bleeding with aspirin reported a rate of, this is higher, 1 to 10 per 1,000 annually in a large cohort study. So, I mean, if there were no potential side effects with aspirin, then it's okay. I mean, not much benefit, maybe you can still try, but there's some risk to it as well. So I think this might be helpful. This is observational, I don't think it's a trial, but again, this is from a strong heart study which says that your risk for coronary artery disease, if you have diabetes, your risk for coronary artery disease increases the number of risk factors that you have, And the more risk factors you have other than diabetes, so you have hypertension, you have higher risk, you have hypertension and cardiovascular, and high cholesterol, you have higher risk again. And then we came to this evidence statement, this CPG statement, which said it's reasonable, we dare not say strong recommendation, it's reasonable to initiate low-dose aspirin for primary prevention in people with diabetes and no previous history of vascular disease at age 50, okay, for men and 60 for women, provided they also have at least one or more of the following cardiovascular risk factors: smoking, hypertension, dyslipidemia, etc. So of course, you still need to always think about the potential for benefit and the potential for risk whenever we start or we modify antiplatelet therapy. Okay, I think that's the end. Thank you for your attention.